So the topic given to me, let's begin with the World War I, and the topic given to me is scientific specialized nutrition support is the way to go. That's what I have studied, that's what I believe in, that's what I practice, and I've seen the outcome. All right? So when we talk about, I think the first, all of us have seen the presentation, how nutrition has evolved over the years, right from Egyptians. We have fantastic formulas. We have good techniques to feed. We have the enteral pumps, enteral or triple chambered bags. We have qualified dietitians. We have an excellent team. But still, critical care nutrition is still a challenge. And if you look at the malnutrition rate, most of the studies say up to 70%. And in a country like India, it could be even more. And if you look at the slide, what are the common conditions that I get to see every day as a dietitian? Someone with a pulmonary failure or a hepatic failure, or someone with sepsis, multi-organ dysfunction, or someone with burns or trauma or inflammatory disease, or someone who's post-surgery. So these are the common cases. Someone with an acute or a chronic pancreatitis. These are the common cases that we usually see and prescribe diets and in the ICU. So an important statement from the Aspen saying that it is no more supportive. It is a definitive therapy as such. So yes, we all agree that it is no more an adjunct, but it is definite therapy. And medical nutrition therapy is the cornerstone of critical care nutrition. All right, so we all know what they go through. Critical illness, we had the ebb and the flow phase. But now you also have the recovery phase. The first 2 days, hypocaloric feeding, and then followed by we don't compromise on protein. And we all know and agree that specialized nutrition is very, very important because to attenuate inflammation or to downregulate the inflammation or help in wound healing or infection rate or decreasing the length of stay. There are enormous health benefits of starting nutrition early. But again, there's a caution of, don't be too aggressive. Refeeding is always there. So, gradually you go on to that. So, an important statement that I would like to make, the recent European guidelines which said, if the patient is not able to take orally sufficiently, what I mean is at least 70% of the requirement is not met, then there's a clear indication that they have to be on nutrition supplement, all right, to meet the adequacy, all right? That's clearly told, and that's what we practice. When we assess the patient, so whenever you know that the nutritional intake is not up to the mark, there's a clear statement that oral nutrition supplement is the way out. And who are all those patients who are orally fed and where you think there is a need for specialized nutrition support? So to begin with, ICU patients, yes? Yeah. So what we practice is, we started with hyperalimentation, and then we came back to optimal feeding. And then what now we have is a goal-targeted feeding in critical illness, where it starts with hypocaloric feeding in the first 2 days of acute phase, followed by gradual increase in the calorie, meeting on day 7. And not to forget, those who get discharged from your ICU, who are on your diet, so attention to be paid to their nutrition as well, giving them high calorie, high protein nutrition. Now, adequacy of oral intake in critically ill. There's so many studies that there's a huge amount of calorie deficit. And we all know that the common cause is, if you look at them, I would say there are studies on people who are on oral tube feeds, parenteral, but very few studies on patients in ICU who are on oral diet. All right? So for them, there was a study where the nutritional adequacy was monitored post-extubation. We have many patients who are, after extubation, who have difficulty in swallowing, who are not able to eat adequately. So for them, how do you manage their nutrition? So there are guidelines who say that general diet plus oral nutrition supplement is one of the important ways to meet their requirement. I'm talking about the acute phase, the first few days where the patient is extubated. Then coming to the post-ICU discharge, we make sure that they are going out of the ICU with proper nutrition. So it's usually, I usually don't call them as victims, but they are survivors, and see that their nutritional requirements are met adequately. And bed sores, which is very, very common. What we have done is, where they were not in a position, most of them were on oral diets, especially those elderly population, those with neurological deficit, they who were on pureed diets, who had bed sores. I think when we have complemented the regular hospital diet with the high protein supplements, that actually quicken the whole healing process and help them to recover. And definitely oral nutrition supplements are very effective in terms of enhancing wound healing there. So to start with, COVID has taxed many ICUs. We had patients, our hospital started the best high-protein diet, specialized high-protein diet for the COVID patients. We tried with many recipes, but it didn't really work. There were many who were not able to eat adequately. They complained about breathlessness, cough, and most of them were on oxygen support. Someone was on a nasal prongs, different kind of oxygen support. So you give them the best diet, but it really didn't help them. So specialized scientific nutrition support is the way to go. When we have added supplement along with the regular diet, I think it really helped them to meet their nutritional requirement. That's what we have seen in this study that we have conducted in the hospital. Various common symptoms, no appetite, altered taste changes, and breathlessness. And of course, they have GI symptoms, fever, infection. Some people had even AKI. All of these. But what we have seen is their food intake, when we have correlated with the length of stay. Obviously, people not eating well stayed for a long time in the hospital. So those selective people who are at nutritional risk or who are already malnourished, who are not eating, where less than 70% was their food intake, when we added an oral nutrition supplement, that's what we call it as specialized nutrition support, with the targeted goal. And most of them, what we could see is, with meeting the targets in the first few days, were the first ones to leave the hospital. So, hepatic failure. What kind of patients that we see in the ICU? Advanced liver disease cases, right? Decompensated liver disease land up in the ICU, maybe progressing to hepatic encephalopathy. So you see them with ascites, you see them with portal hypertension, esophageal varices, and bacterial peritonitis because the ascitic fluid gets infected. And look at the factors that interfere with nutrition. There are a whole lot. Even if you give them 2 spoons of food, they say they are full, satiety, because of the ascitic fluid. And you give them the best diet, and then how will they be able to eat? So adding a nutritional supplement, going the specialized way, has actually helped them. And what I mean by a specialized is, small frequent meals accompanied with a calorie-dense formula. Because already there is ascites, they're not able to eat. So I would choose a calorie-dense formula. And of course, do not forget the late evening snack. So something which is enriched with branched-chain amino acids, all right? And their glycogen stores get exhausted. So probably a supplement. And BCA, and there are many studies on that, where it helped in protein synthesis. It doesn't improve encephalopathy, but it definitely helps in protein synthesis for these patients. So these are the scientific approach that I would say. Cancer. Breast cancer, I think, is the #1 cancer. And we have more of head and neck cancers. Nowhere in the world has that high statistics. Head and neck cancers are highest in India. And these are the patients that we see. And cancer cachexia. We've handled hundreds of patients with cancer cachexia, cancer with METs. You give them the best food, they wouldn't be eating. And the muscle wasting is so much, they become emaciated. No matter whatever cancer that you're dealing with, of course, most commonly seen in GI cancers, but whatever cancer it is, they are malnourished. And at that point of time, I don't really think that, what really could help them at that point of stage, where to meet the nutrient requirement is, again, the specialized nutrition support. If you see the picture, one of the patients that I've put, he was there almost for 3 months. It's a cancer of larynx, but it's a very rare surgery that was done. He's from Kenya, and then, tracheostomy was done, and then we tried the pureed, semi-solid diet, but what actually saved him is because we anticipated that before surgery itself, we tried to improve the nutrition with oral nutrition supplements, and then a feeding jejunostomy. That really helped them to maintain the adequacy, and now his discharge from the hospital. So cancer cachexia, the guidelines clearly say when your oral intake is less, which is bound to happen in most of the patients, then what is the best way that you deal with? Something with anti-inflammatory, high protein, a calorie-dense formula is always the best way to go about it. And there are many studies which have proven and how it helped them. Chronic kidney disease, most common who land up in the ICU are CKD managed with medical management. Suddenly they come with fluid overload, metabolic acidosis, and they come with uremic encephalopathy, right? And what do you give them? Even their saliva composition changes in stage 4. You give them the best diet, they wouldn't be able to eat. And for the first time when the dialysis starts, it's a nightmare for the patient. So when you look at the hemodialysis, patients on peritoneal or hemodialysis, look at the number of dialysis centers in India. When I have seen dialysis centers abroad, the lifespan of the patients is like 15 years or so. But here, it's very, very less. And the kind of food that you provide, there's a financial burden, of course. So why is because nutrition is always neglected in this set of population. So it is a high catabolic condition. And I would say that the requirement, we all know, when it comes to protein, calories, micronutrients is huge. So along with the diet, when they have added on a prescribed an oral nutrition supplement, it helped them to improve the albumin level and overall quality of life. We have done a study on integrative approach in dealing with these patients. If you look at them physically, don't judge book by a cover. They all look healthy because of the fluid overload and all that. But if you go inside and see the body composition, they're actually losing a lot of muscle. So clearly, when the nutrition intake is less than 20 kilocalories, when you think they're at nutritional risk, oral nutrition supplement should be added. I'm not talking about intradialytic PN, I'm talking about intradialytic enteral nutrition. That could be given. And do remember, every dietitian, whoever enters the dialysis, every day should be remembered that for each dialysis session, a person will lose about 6.8 grams of protein. And how do we meet that? And you have IBD, and both important conditions, Crohn's, and you have ulcerative colitis. And Crohn's, there are more malnourished patients in Crohn's compared to ulcerative colitis because your entire GI tract is affected. You talk about exclusive enteral nutrition. That's what we practice in our hospital. When they have a flare-up, they're having 10 to 15 loose motions, blood motions, they're not able to eat. Now, I couldn't be thinking about the best recipe that I could make up with, but all I could do is a semi-elemental formula, exclusive enteral nutrition. That has actually helped them, otherwise using the steroids. So we talk about ERAS protocol, where you minimize fasting before surgery. And even post-op, surgeons were hesitant. The clear liquid diet is outdated. So you try to feed them on the day of surgery. And obviously, when the nutrient requirement is less, you got to intervene and see that adequacy is met by adding a supplement. So post-operative as well. So clearly, the guidelines say that, yes, if the nutritional intake is less, then adding a supplement is definitely an important decision. Stroke, again, you have ischemic stroke or hemorrhagic stroke. Many patients recover, but some have, dysphagia. Swallowing is impaired. I'm talking about those set of patients who have dysphagia and where swallowing is impaired and who stay for a little longer time in your ICU. There are studies which say that your dysphagia diets, calorie intake is less when compared to when they were tube-fed. The calorie intake was faster to meet. I'm talking about the acute phase in the ICU. I'm not talking about the first few days in the ICU, all right? So additionally, to meet up the requirement, because they lose a lot of proteins, so meeting up with the formula along with the pureed diet would be the best specialized nutrition way to go. So clearly, the guidelines say that if the nutritional intake is less, which is bound to happen because of dysphagia in these patients. And chronic pancreatitis, what comes to our mind? Malabsorption. All right? Malabsorption is the most important thing. So what is the best way? Combine oral nutrition supplement along with your regular diet so that, you improve their nutrient intake. So most of them have endocrine, exocrine dysfunction, and chronic pancreatitis. Again, they are emaciated. And they might be eating, but it's hardly absorbed. So there you need to intervene. An elemental formula or a semi-elemental formula with MCT definitely would help them. And orally fed are at high risk of calorie protein deficit in ICU. These, I feel, are the neglected set of population. I mean, we think about the ones who are on tube feeds, but we never bother to check who are on oral diet because we take it for granted. Oh, we are giving the best diet and they are happily eating. We don't bother to check their thing. So I think the dietitian woes worldwide are the same. Monotonous diet, no choice, therapeutic restrictions. I'm feeling too weak in the ICU to eat. Procedures, aspiration risk, malabsorption, and so many GI intolerances because of the drugs. There is gastroparesis, delayed gastric emptying. You give them the best thing, but what is the intake? That is the question. All right, so there are many, many observational studies which talk about calorie deficit. And the most famous study by Philipson, who said your hospital stay each day, the amount that you spend on a formula, and you look at the hospital cost is, comparatively less. So the key points that I just wanted to make clear that inadequate oral intake is very, very common, looking at the malnutrition rate, specifically in the ICU population, if you look at. And calorie deficit associated with poor nutrition delivery in ICU are associated with worst outcomes. We all know nutritional status is a prognostic factor, and it's the definitive therapy. So artificial nutrition support is essential in managing these critically ill patients. And the take-home message of my thing is, ONS is an effective, non-invasive solution to your malnutrition. That's the take-home message. So what is it? Aggressive medical nutrition, individualized, as rightly pointed out. Not one size will fit everyone, but it is personalized individual nutrition. That's medical nutrition therapy, and hopefully, that will improve their outcome. I think that's the way to go, specialized nutrition therapy. And the last one, if someone asks me what is the impact of nutrition on critically ill, I would say at least it will help them to survive. I think both, isn't an option, but it is a necessity, both medically as well as ethically. So that's the way forward that we have to go.
Thank you, Dr. Sunitha. I would request you to be seated over here. Meanwhile, I'll invite Dr. R.D. Shivashankar. Please come. He's a Chief Clinical Nutritionist and Dietitian at Tata Memorial Hospital. And thank you, Dr. Sunitha, for giving such an elaborate lecture. But I think now, to counter the point that specialized nutrition is important, natural kitchen-based feeding is a better way to feed critically ill orally fed patients.
Natural kitchen-based feeding is the better way to feed critically ill orally fed patients. My friend Sunitha madam, every slide were convincing, evidence-based. I did walk out of the auditorium because who can and what you can speak on this topic. Everyone is aware what is the present situation, what are evidence-based guidelines, what they talk about. And Dr. Sanjit did convince me, Shiva, tu nahi baat karega to koi nahi baat karega. And due to his friendship, I agreed to talk on this topic. A very tough one. I really don't know how I'm going to fare up for this topic. Before that, this is a disclaimer. The presentation is just for the sake of the topic justification and not to downgrade any evidence-based nutrition practice and any other alternatives. Thank you for acknowledging that. Thoda sa jaan aa gaya abhi. Fine. Really, the topic is really very tough. It's a lost battle where he has pushed me here. And as I said, my friend, every slide was convincing. In what way I can really put my case in a stronger way, let us see. The most biggest question, when it comes to when you compare a commercial and the kitchen-based, hygiene, nutrition, and affordability. The last part, we can always keep on banging, affordability. Kitchen feeds are affordable. No doubt about it. First two part में we take a back seat. हाँ यार, hygiene. Cook कैसा बनाता रहेगा, वो कैसा देता रहेगा. Then how it is being distributed, how the patient is going to handle, how the patient is being fed, how long the patient is fed. These are the questions which are going to mark over here. Nutritious, no standardization. Yes, of course, here also we are being challenged. Let us see what is there. If you had seen the first video what was played when you entered the auditorium, I felt so happy when this story was briefly mentioned about in that particular video. James, US President, he was shot in 1881. 3 bullets were fired to the back of his side. Thereafter, he collapsed over there and he got his ribs, small intestine, pancreas, vertebra damaged. He was not able to stand. He was taken to the ICU and he was in the ICU for 87 days, even though the video spoke about 74 days. But there are many papers on this one which will talk about 84 days, 87 days. Doesn't matter. Even if you take 78 days, it's almost around 2.5, quarter to 3 months. That's a really huge number. And for 3 months almost, he was fed, as you saw in the video as well. And my presentation coincided with that. With all the blenderized soups, he was given beef broth, wine and many other things which were made into the kitchen. And he did survive for 87 days. But why did he die then? He died because of the infection caused the way the bullets were removed and not because of the malnutrition. So, nutrition cannot be blamed. This is, I am talking about 144 years back. I am not talking about the day of what we are discussing over here. So, it means what we started was really good. Nothing wrong in that one. Okay. Further, we'll go back. We'll see what the Egyptians had done. 3,500 years back, even they practiced enteral nutrition and they gave the home feeds only. And we really don't have a data how many patients died because of the home feeds were fed to the patients. We don't know. But we cannot claim because of the food which was served from the kitchen, the patient did die. Okay. This shows the feeds were hygienic, but are they nutritious? Let me try to answer this question as well. This is a patient very recently, around 2 to 3 months back, he came to our OPD and to the evidence, because we want evidence, isn't it? My friend did present so many evidences. I really don't have a lot of many papers, and whatever the practical evidences I get, and I did started collecting in the last 2-3 weeks, and what I could accumulate, I'm going to present over here. You can see this patient. Can anyone tell me what is this patient is about? Anyone can tell how this patient is fed? What is the TEP is mentioned over there? It is not written by me, it is written by the doctors long back. And the file, when it was created 2010, we are into 22, 12 years old this patient is. This patient is taking the feeds through the openings, that is the stoma, what you see on the throat. That is known as total esophageal puncture. No more it is being practiced. And when this patient came to the OPD, the doctor immediately wrote TEP because people will not understand what is it for. So only because I had seen at that time what is TEP and how it was fed, and this man is not on supplements. He is on homemade liquid diets, not even soft diets, no kheer or something like that. He is taking only liquids. And you can see his health. I don't have to make any further comments for that. Isn't it convincing? Ek case ho gaya. What about the other cases? You speak more about it. One of chances you can always take it, isn't it? This is a second case. Very recent cases over here. Lip composite excision was done, segmental mandibulectomy, and 2013 patient it is, almost 9 years now. And the diet charts you can see, and over there you can see the graph also is moving up. He is again not on supplements. He is a very poor patient. We cannot afford to tell him to keep on taking the nutritional supplements and nourish yourself. And I'm not, as a dietitian, I am never into a hospital to feed the patient. I am there to nourish the patient. Always remember this one. And this patient was getting nourished. This patient was getting nourished by the feeds made in his own kitchen. And he walked out of the hospital because the kitchen feeds were taken care of him. Further, one more example. Tongue wide excision via pull through, then neck dissection was done, and this patient was not able to take anything, only Ryle's tube was the only source where this patient was to be fed. Again, this patient is on home feeds only and not on ONS, even though earlier on we did use ONS to nourish him. Thereafter, when he went home, again you can see quite above, if you can able to really make out, September this patient had come to us. Till today, no poor patient can be on ONS, getting fed himself and spending around 600 to 700 rupees daily. And again, see the health of this patient. There is no fudging in the diet charts. I have not remade any diet chart. This is a diet chart. If at all, if this patient comes to your institute for any reason, you can just go through the file, you will find this diet chart intact over there. Finally, one more case, hypopharynx. This patient is also a lady. You can see the health of this patient. Again, quite healthy. And it is not just for 15-20 days. Yes, this patient, almost 2018, she had registered over here. And there, 22nd February I saw her. In the last time when I saw her, this was on 22nd February. She looks still healthy. So they were hygienic, nutritious, and affordable. So let's see some shocking evidences which we need to really know, and maybe there are some hidden messages to everyone over here into this auditorium. And how far you can rely on commercial formulas and their companies' claims and the certification by the government agencies. These are being, I am putting with a very conscious question mark over here. And let us see what the evidences talk about this. SPEN guideline, we are very fond of all guidelines. So I am highlighting, just focus on this part. What the SPEN guidelines on enteral nutrition they are going to talk about. Of course, they are talking about home enteral nutrition. Survey of adult OLE Foundation members, almost 70% of the 91 respondents indicated that they used blended tube feed. In another survey of blended tube feed used in the community, 30 of the 54 respondents reported improved tolerance and fewer adverse gut symptoms with blended tube feeds, while the remaining 24 respondents choose not to use the blended feeds. We have a conflicting results over here. They have not ruled out the blended feed tubing, even in the guidelines. Further, if you see the same guideline, if you go on reading, now if you see what they say, in addition, 203 Polish patients were switched from blended tube feed administered between 5 to 6 times each day to commercial tube feed administered as boluses or continuous infusion under the direction of a specialist. The outcomes, here I am going to lose my battle again. The outcomes included fewer hospital and intensive care admissions and less frequent pneumonia, urinary tract infection, and anemia requiring hospitalization. Actually, this slide should be belonging to my friend, but as I said, I'm sorry ma'am, but this is nutrition boot camp. So, if you read in further, what do they say? In this study, a care package was provided to the people who were on commercial feeds. Don't you think this study is a biased one then? You provide a special treatment for the patients who are on commercial feeds, and those who were blended on the blended feeds, they were just let out on their own. So this is wrong. That is why the interpretation was challenged. Further, blended tube feeds have been considered to be time consuming and therefore costly to prepare, with one study finding that time and non-nutritional cost could account for more than 50%. How can this be possible? More than 50%. Further, they say, the same study also found there to be poor standardization of blended tube feeds and risk of microbial contamination and product instability. Again, I am talking on behalf of my friend. Let us see what is there in store. It is of note that 4 of the 5 authors of this particular study were affiliated to commercial enteral nutrition company. I am so sorry, madam. Fine. The recommendations, how they are passed, do we read about this one? Arey, pass kaisa hua? What did they mention about it? What did they do the studies? Let us see. As homemade blenderized admixtures are less effective than EN formula or commercially produced whole food solutions, they should not be utilized in patients of home enteral nutrition. How many people agreed? 63%. So 63% will overrule all those people who are sitting over here. Even if you agree to me, you have to follow these 63%. Even those 37% of the people were on my side. Doesn't matter. Further, recommendation 39, standard commercial formula enteral tube feeds can be used unless there is specific justification for blended tube feeds. Again, they are not ruled out. And what is the agreement? 92%. You are going to agree for the 63% and deny the 92%. How it can be done? Further, we'll see. Does these ONS do cause any problems? These are certain kind of side effects or the allergic reactions which were happened, certain ONS were administered. And we always document such kind of things for our own purposes. And when the ONS were withdrawn, after 1 or 2 days, these are the signs which subside. These are only the 3 patients what I have put it across, but there are many. How many times you have come across such kind of allergic reactions with the kitchen feeds? Has anyone experienced of this one? I have not seen in the last 25, 26 years. 2 more minutes. Selection of appropriate enteral formula. So which formula should be used? Okay, what they say, based on expert consensus, we suggest using standard polymeric formula. Standard polymeric formula. All those practitioners, if you know what is standard formula, you all know that jahan pe bhi standard aa gaya, that's a standard formula. Because the polymeric standard formula definition, they have not defined what is a standard polymeric formula. For us, whatever is available, the standard polymeric formula, the characteristics you should be knowing for that one. The target energy proteins, we all know, it is 25 to 30 kilocalories and 1.2 to 1.5 grams, 2 grams of protein. This is what they are recommending. And you are going to use the standard polymeric formula to meet this one, these target values. Let us start just for an example. I will take the baseline 25 kilocalories and 1.2 grams of protein. So I am within the recommended guidelines. Let us take a patient who came to you for 65 kgs and you want to plan a 25 kilocalories and 1.2 grams of protein for this patient. A very conservative kind of a calculations we will do. And let us see, I have this whole milk. Just for the sake of this presentation, I'll take a very humble kind of a simply available, most cheapest in every hospital, every corner of our country, this will be available, the cow's milk. So I try to meet the protein content of the target values, that is 78 grams. So to meet 78 grams, I need to use 2363 ml of whole milk. Fine. But I am giving 1725 kilocalories, that is 100 calories more than my calculations. I think nothing to worry about it. 100 calories to fir bhi chalega. Everyone knows, even after all the guidelines, we are underfeeding the patients. Anyone who would disagree with this? We do underfed our patients. Fine. I tried for semi-skimmed milk, but I couldn't really match up with the target values. I am going to underfeed the patient almost 250 kilocalories. The third option, I took whatever the available standard formulas available in our country. Randomly I selected sample A, I don't want to name which is this one. To meet the 78 grams of protein, I ended up giving 1860 kilocalories. That means I was overfeeding this patient by 235 kilocalories per day. Overfeeding is again dangerous for the patient. Everyone knows that hyperglycemia, infection and all those other things we do come across, and the patient ends up into greater number of mortality and morbidity. Sample B, very close to the one. Again, I won't name this one. 1500, volume is really good. 78 grams of protein. Calories 1635. Very encouraging this supplement. Further, if you see, sample C, 1902 volume. Volume is good, but to meet 78 grams of protein, I am feeding almost 300 kilocalories more than the requirement. So where is the standardization? You are talking about, you are questioning the standardization of the kitchen feeds. But here is the question of standardization of the standard feeds. You are going to select a standard supplement randomly. You are not going to read the labels. How many of us are really going to read the labels and say, okay, guidelines say commercial feeds, then I will be sticking to the commercial feeds. Sample D, that is 2 kilocalories per ml. Even though the guidelines say 1.5 ml also you can take, doesn't matter. If you take the 1.5 ml per 1.5 kilocal per ml also, it will be the middle average of sample C and sample D. If you take the 2 kilocals, you use only 500 ml, you give 78 grams of protein, but you end up overfeeding by 600 kilocals. You can do all these calculations whenever you have time. So we all understand all these ICU patients who will be into hyperglycemia.
Dr. Shivashankar,
Just 2 minutes last. Yeah, we are almost ending. Hyperglycemia, inflammation, and insulin resistance, and all these complications do come across. So what kind of feed needs to be administered then? So I do recommend over here the milk which will not raise your sugars, no question of hyperglycemia, glycemic index is low, glycemic load is low, sample A, B, C, you can see if I am going to use any of the standard feeds, I am going to deviate from my target values. Ultimately, who is the beneficiary? I don't want to answer. You all are quite educated. You can have your own answers. Almost second last slide. So same question to the commercial formulas, inconsistent in micronutrients. You always believe what has been printed on the labels, isn't it? You will never question that one because it is being approved by some agency. And this is one of the very recently I came across. What is wrong in over there? You can see the totaling comes to 105.33 grams of the nutrients compacted in 100 grams. How is this possible? This is magic. This is magic. Then you should believe the magic. How can 105 grams of material you can infuse into 100 grams? Isn't it? So we are dealing with the magicians. So worried about infection, best example is to improve TPN handling. When TPN was introduced, Dr. Sanjit would agree that 10 years, 15 years back, the incidence of infections were very high. Today it is not. Why is it so? The handlers are better trained. If you are questioning the hygiene part of the blenderized soup, it is a training which is required. Feed should not be blamed for that one. Ultimately, at what cost? If you see the costing, what it is coming to 130 ml, 130 rupees if you are going to spend for the milk, that is a Tetra Pak one. You are spending 714 rupees for sample A. Ultimately, an average of 600 rupees per day per person if you are going to spend, in 1 month, you can see 1,80,000 is extra spent, and in 1 year, 21 lakhs and 60,000 rupees. Why can't you use this money to upgrade the kitchen or the feeds which are being supplied over there, or to train the employees or train the nurses at the stations and at the ICU? So better utilize the money, bring down the cost. Every hospital talks about bring down the expenses and see a better treatment can be given to the patients. So don't doubt on nature when skill is suspected. Thank you.
Thank you, Dr. Shivashankar.
Sorry for taking extra time.
Thank you very much. Thank you. I think we had already overshot the time, but the important part which both Dr. Sunitha and Dr. Shivashankar pointed out is that sometimes it is too much ado about nothing, but at the same time, a lot of things come out of nothing. So nutrition is definitely not the Cinderella anymore who has to be mistreated, but somebody who needs to have both the balance of finesse as well as the skill that we are talking about. But I'll just put certain comments and just close this session after that. That how do we make, and the whole topic which actually we digressed from was that specialized nutrition in critically orally fed patients. So both the ways, even for orally fed, I would ask Dr. Sunitha, how do you make this ONS more palatable, better texture of natural food, fiber and appealing? So that's something which is a challenge which I think all dietitians and nutritionists will have to work for those sick patients who are struggling to have food, who hate the sight of food, how to make it palatable. And for Dr. Shivashankar, the same questions about how to get the sourcing of raw material, the same question about labeling comes for the sourcing of raw material. The bedside pantry versus kitchen which is far away in another building, variability of calories in food habits, and a disease-specific adaptation. So one final comment from both of you, and I think we will be able to close this session.
I think my friend got it wrong. Dr. Sanjay is very tricky. He said orally fed patients. It's not the tube feed. ICU orally fed patients. So who are those subset of patients? So just one question, sir. You have a case who is on CRRT, who has a fluid overload, and you got to meet 2 grams of protein. How do you do that with the so-called natural diet?
The first thing is like, I would answer for that one. To take the messages in the right way. There is a plus minus points in both the sides. We have to accept very practically. A question put just for the sake of this session, I would say that you can always play with the kind of calorie and protein required from the kitchen sides, but not exactly the way you want for the critically ill patients, what the topic has been given to me. A critically ill patient who is not able to actually take orally anything. Yes, agreed upon the flavors and other things. When you come to the flavors, then again the flavor fatigue is also existing. Remember that one. But flavor fatigue is not existing with the kitchen feeds or the natural foods. You can eat chapatis 3 times a day, doesn't matter. But if you drink the same vanilla flavor 3 to 4 times a day, after third, fourth day, it is going to subside at any cost. So we should agree even that one also. Then you have to think about the next flavor and other flavors and all other things. There are clinical conditions, madam did mention about that. Even the volume also you can rework out on that one, considering the kind of a protein-rich elements which can be added to the milk feeds or maybe any other things, which we are already well versed of compositions. Thirdly, sir did mention about how we are going to the labor charges and procuring the things to the unit and all other things. A very simple solution, I would say. You have a coffee vending machine. What they do, coffee powder and milk is being put over there. You mix it and then he is going to give you the same machine. You can put it in the ICU. You have your milk, which is steriled, and if you want to add some more protein powders like soya or anything to increase proteins and decrease maybe volume, you can still work out in that way. And it will be sterile, hygienic, and the content, the nutrient, everything will be sterile. I can vouch for this one. Maybe we can have a workshop on this in the next boot camp, and I will show any kind of nutrient density and calorie density you can give me, and I will give the formula for that. Thank you.
Thank you. Thank you. It was a wonderful session. I thank both the speakers for that.